So HRT stands for hormone replacement therapy, and it does what it says on the tin. It's replacing the hormone that we're lacking as we go into the perimenopause and menopause. The main hormone that we notice the lack of as we get older is estrogen. That hormone affects every system in our body, and by replacing it, we can help a lot of symptoms that we start noticing as we get older. So the benefits of estrogen can be quite widespread. Estrogen affects our brains, it affects our skin, our muscle, our blood vessels, our bones. And the kind of symptoms that we may notice and that may be helped by HRT are the obvious ones like hot flushes and night sweats, but it can also help our sleep generally. It can help with anxiety and mood changes. It can help with palpitations. It can help our skin. It can help dry eyes and sore gums. It can help with vaginal dryness and soreness. And it also has some more hidden benefits. So it can help protect us against osteoporosis and also against cardiovascular disease. And by that, I mean the increased risk of heart attacks and strokes that women get as they get older, and the estrogen that has protected them against these things in the pre-menopausal years reduces. Osteoporosis is thinning of the bones and can cause an increased risk of fractures as you get older, and HRT can help to prevent this also. So there are lots of benefits. Indeed, the mortality for women taking HRT, so the death rate, if you like, is lower than in the general population. So it's generally a good thing, and it's safe for most women, but not for all. So there are some risks attached to taking HRT, which I will talk about now. The risks of taking any medication are always in the leaflet that comes with it. So if you take the leaflet out of the paracetamol packet the next time you buy one and read it, you probably will be frightened about taking paracetamol. The same is true with HRT, because there are risks, but they are very small and they need to be contextualized. So when we think about risk, we tend to find that we're told about relative risk, so about the increasing risk that a certain kind of treatment, such as HRT, gives us. What we don't get told is about the absolute risks, and that means the background risk and the effect of HRT on that. And that's really important to understand. So to try and explain it in figures, particularly for breast cancer, which is the risk that most women have heard about and worry about in taking HRT, if we try and put figures on it, then I think the best way of thinking about it is to think about 1,000 women in the general population in their 50s, so between the age of 50 and 59. Out of 1,000 women, 23 of them will get breast cancer between those ages within a 5-year period. If you give those women HRT, then an extra 4 will. So instead of 23 women developing breast cancer over a 5-year period, 27 will develop breast cancer. So that is an increased risk, but in the scheme of things, it's a small increase on top of quite a small risk. So if you think about it the other way round, 977 women over a 5-year period in their 50s won't get breast cancer. And if you give them HRT, 973 women won't get breast cancer. So I think that contextualizes it. The other way to contextualize it is think about other things in our lifestyles that affect the risk. So if you drink alcohol, and you don't have to drink much alcohol, so 2 or more units a day, your risk increases by an extra 5. So instead of 23, it's 28 per 1,000. And if you're very overweight, so if your BMI is over 30, your risk increases by an extra 24 per 1,000. So that's actually feels very significant, doesn't it? That's a doubling of the risk. But it still means that only 953 women out of 1,000 won't get breast cancer. So you can see that even doubling that risk makes actually overall not a huge difference. And I think it's important to think about risk in those terms. The women that we do worry about, however, and the reason that when you first talk to your doctor about taking HRT, they'll talk to you and ask you questions about your underlying health, is because there are some women for whom it is more risky to take HRT. So those are women who have had breast cancer or who have breast cancer. Those women have an increased risk of developing further breast cancer or recurrence of breast cancer if they take additional estrogen, if the tumour that they've had is estrogen sensitive, which a lot of breast cancer is. So for these women, the risk is higher and is much more significant. There's another group of women who have a very strong family history of breast cancer who equally we would be very careful with, because their background risk is quite a bit higher than that 23. And those are women who have a first degree relative, so that is a sister, a mother or a daughter, who have developed breast cancer before their menopause. So if you develop breast cancer after your menopause, that's much less significant, and while your doctor will talk to you about it, it probably doesn't increase your risk, particularly as the relative thinking about taking HRT. But if you have a first degree pre-menopausal relative who has had breast cancer, your risk is higher. And those women probably need specialist input into assessing the risks versus the benefits of taking HRT. So that's the main risk that people worry about. The others to think about are less of a problem, particularly now when we often give HRT through the skin. So we know that if you've had a long gap between your menopause and starting HRT, so that means 10 years or more, there may be an increased risk of developing cardiovascular disease going forward. So that means heart attacks or strokes. And so we would be very careful with those women to discuss all the risks and to think about starting a very low dose, if at all, of HRT. For other women, actually, particularly if HRT is started in the first few years after menopause or in the perimenopausal period, HRT is probably beneficial to their overall risk of heart attacks and strokes. For women who have had previous clotting, so blood clots in a leg, a DVT or a PE, we need to be careful, but we now know that if they take their HRT transdermally, so that means through the skin, they really don't have an increased risk. So there are very few groups of women now who really can't take HRT. And that brings us on to the way in which we give the HRT. So we always used to give it as a tablet. Here's a packet of estradiol tablets. So this is pure estrogen, type of estrogen, and it comes in a calendar pack. We still give HRT like this to some women. It also comes in a calendar pack with progesterone as well, and this can be taken either each day throughout the month or for half the month. The progesterone part of the HRT needs to be taken for at least half the month, but for older women who are past their menopause, it's probably better to take it every day so that they don't have to have a bleed. Nowadays, however, we're more likely to suggest for a lot of women that they take the HRT transdermally, the estrogen part anyway, through the skin. And the reason for this is because taking these pills, you need to take a higher dose of estrogen because it has to be broken down in the liver before you get the benefits. And therefore, sometimes the higher dose can cause side effects or problems. So the transdermal or through the skin forms of HRT are either a gel, a patch, or a spray. The gel looks like this. This is estrogel. It comes in a pump. You put one pump into your hand and then rub it either onto your arm or your inner thigh. The normal dose of this is between 2 and 4 pumps a day. It also comes in a little pack like this. This is Sandrina gel. This is just the same stuff but more concentrated. Again, you rub it onto your skin and let it dry. Or a spray that looks like this gets sprayed onto the inner arm. And the dose of this is usually between 1 and 3 sprays a day. So that's the estrogen part. You can also use a patch. This is very popular, especially at the moment when it can be harder to get hold of the other types. The patch is actually translucent and the silver foil is the backing. This you stick onto any patch of flat, clean, dry skin. Stick it on, hold it on for a few seconds so it's stuck properly. Again, you can stick it on your the bottom of your back, your abdomen, the top of your thigh. These particular patches get changed twice a week. There are other types which you can change less frequently, but these are the ones that are probably easiest to get hold of. And this is pure estrogen or estradiol in this one, but you can get combined patches which have progesterone in as well. And again, these either you have patches which are all the same, which contain some estrogen and some progesterone, and then you're taking continuous HRT and not having a bleed, or you have a packet which has half patches which have both estrogen and progesterone in and half which just have the estrogen in, and then you have a cycle and a bleed. You may wonder why anyone would want to have the cyclical patches, but actually taking cyclical HRT is probably more sensible for younger women because if you take it continuously and you're still cycling underneath, so you're still having your own natural cycles sometimes, unfortunately you often bleed quite irregularly, which is obviously very annoying. So it's probably better to keep with the cycles until you are a bit older, and then you can go on to the continuous combined types of HRT. So the other way that we give the progesterone nowadays quite commonly is this, which is micronized progesterone in a capsule. This is a great form of progesterone. It's very similar to our own natural progesterone, bioidentical in fact, and so it's less likely to cause side effects and problems. We take this, usually we recommend taking this at night because it can make you sleepy. And again, you can either take it cyclically for half the month, 2 capsules a night, or all the time, just 1. So this is commonly prescribed nowadays. The other way that we give the progesterone is through delivering it straight into the womb through a coil, which looks like this. So this is, believe it or not, the size of your womb. And this is a Mirena coil sitting inside. You can see here there's a little sort of collar which has progesterone in it, and that gets gradually released into the lining of the womb here and stops it from building up. This obviously has to be inserted. Don't worry, when it gets inserted it's in a little tube, so it doesn't have these arms sticking out. It's inserted like this. But obviously it's an invasive procedure which can be uncomfortable. Usually not particularly so, as we use a local anaesthetic gel, and certainly for most women who've had a vaginal delivery, it's not much of a problem. It's great if you have problem periods in the perimenopausal time because it stops them. So you stop having periods, which is fantastic. So for younger women who don't want periods, this is a really good option. It's also contraception, which is good for younger women because HRT isn't contraception. So there is always a risk of pregnancy. So that's the different forms of HRT in a nutshell. There's two things I haven't mentioned. One is vaginal HRT. So we can give a very small dose of estrogen directly into the vagina to help with those specific symptoms. It doesn't really then get absorbed systemically, so into the bloodstream, and so it doesn't go to the other bits of our body. So it doesn't really help with our bones or any of those other symptoms, but it can be really helpful for the vaginal symptoms. And it's therefore very useful for women who don't want to or who can't safely take HRT for other reasons. There are different ways of delivering it. This is one method. This is a little tube that you put a little, or comes with a little white tablet in the end. You insert this into your vagina and just push it in until it stops. Usually doesn't go in that far until that happens. And then you push the end and that delivers the little tablet to stick onto the side of the lining of the vagina, and it gradually gets absorbed. You can also get a cream or a gel that's delivered in the same way through a similar kind of applicator. So it's very thin, easy to insert for women who perhaps have narrow entrances to the vagina. You can also get it as a ring, a little, I haven't got one to show, but a small, very thin silicone ring, which you, rather like an elastic band, can push so it's flat and then push inside. And that can sit there for 3 months, gradually delivering a little bit of estrogen every day into the vaginal tissue. Those are both, all those forms are very safe because it's a tiny, tiny dose, much, much smaller than, you know, even a single tablet of HRT. So it can be great for older women who perhaps don't want to take HRT, or it might be too risky for. And we even use it sometimes for women who have had breast cancer and who are getting terrible vaginal symptoms because it's that safe. So that's one other method of delivering estrogen to the body. The other thing I haven't mentioned is the use of testosterone. This is something which is sometimes suggested for women who are already taking HRT, but who are still having problems with their libido. There is evidence that it can be helpful to improve libido, so sexual desire, in women who are taking HRT, who seem to be absorbing it well and are still having problems. But for most women, it's not necessary. Most women, as long as they're taking enough estrogen, don't need it. It does have to be monitored with blood tests, and there isn't a licensed testosterone product in this country. So women have to use tiny doses of male testosterone hormone, again delivered through the skin as a gel, which can be a little bit difficult because it's difficult to get quite the right amount. But it can be useful for some women. However, for most women it's not necessary, and because of the monitoring and the fact that it isn't licensed, most GPs don't prescribe it without specialist oversight. So it's something that you might well need to be referred for if you need it.